So thank you for coming. Introduce ourselves again to you if you don't know who we are. Many of you do. Some of you probably could do the introductions. I'm Jeff Turcott.
Kelly Kurtz.
And our business is Simply Well Seniors. And welcome again to the next chapter of Simply Well, Aging Well seminar series. So today we're talking about home health, hospice, and in-home care. It's a panel discussion. We have a wonderful panel today. And Kelly's actually going to be the moderator today. So that's something new, but give her all the support you can give her. Just to let you know, again, who we are, and our tagline is helping seniors navigate the journey to the next place they call home. Some of the things that we've been working on since the last time we saw you is a home with a family in Lunenburg that actually went under agreement in, what was it, 4 days?
Yeah, probably 4 or 5.
Yeah, 7 offers, over asking. Everyone's thrilled. So that's a success. So we're hopefully.
It was a big downsize. This family lived in the house for 40 or 50, well, for almost 50 years. So lots of decluttering, lots of donations, estate sale, the whole bit, to try to really get them to a point where they could be able to sell.
Lots of treasures.
Yes.
No?
Hidden treasures.
Hidden treasures. But I thought, so I added one more slide to kind of show folks, we're actually meeting with another family again next week. This will be the third meeting about really what it is that we do and how we help families throughout the whole process. It's Kelly and I kind of shorten it up and say, we'll just get it done, all right? That's what we do. We get to the finish line. So really there's 3 divisions of our business. Simply Well, Simply Organized. If you've ever seen Kelly's Honda Element with her logo on it, can't miss her. If she's at Marshall's, just chase her out.
But this the checkout.
But this is the division where the downsizing, decluttering, organizing, the removal of donations and recycling, and some consignment. That's that part of the business. We have folks that help us do that as well when needed. And then of course there's Simply Well Seniors, which helps coordinate the vendors for estate liquidation, junk removal, if there needs to be interior or exterior repairs, landscaping, those kinds of things, we coordinate that as well. There's one family that we're working with, we may have to coordinate and get quotes for a septic system that has been redesigned and needs to be installed. And then we also offer move solutions for folks that are maybe downsizing into a smaller home or a condo or maybe assisted living, and coordinate with the moving company, pack personal belongings, unpack and set up at a new home. And again, we have other folks that help us do that as well. And at the very end, the sale of the real estate. And we provide professional staging, professional interior cleaning, professional photography, a lot of professional stuff going on. The MLS listing, public open houses, and we coordinate all the showings. And typically when we're showing a house, we are accompanying all showings. So rather than just giving out a lockbox number. Where some folks, that's where we differentiate ourselves a little bit. So that's the whole package. That's the whole schmear that we do from clean out to closing is how we handle it.
Yes, and the purpose of all of our seminars are really just informational in nature, not sales pitching, trying to get you to do any of these services, but just providing topics that are interesting and necessary for seniors who are thinking some along these lines of the next steps of where they may go or what kind of information they might need. So we're trying to provide a variety of topics over this year. This is our sixth seminar, as Jeff had mentioned. We've got them planned all the way out through December. So lots of great topics coming up as well.
Great. So today we're talking about home health, hospice, and in-home care. So go ahead.
So I'm not sure where. Oh, you want me to?
Right there, yeah.
Okay, kind of talked about that, right? But all right. So as a downsizer, declutterer, and stager, we usually help people with a variety of things, as we just talked about. But we usually get 3 types of meetings that we or conversations we start to have with folks when they first contact us. Mm-hmm.
Yeah, so these are with folks that are planning to move now, right now. We were speaking with someone that manages assisted living. She's actually the intake person. And she said she had a family that she'd been talking to here and there, and then they called her one day and said, "Can we move in tomorrow?" like, because something happened, so.
Yeah,
it's
the
like,
fire drill.
That's the fire drill. We haven't had quite that kind of fire drill go on yet, but people who are planning to move now, people who are planning to move a little bit later, maybe later in the year, 6 months.
2 years.
2 years, those are great folks to like to work with, planning with. Or those people who are planning to age in place through the end of their life, whether it's in this house or maybe another smaller house. And then there's people we run into that say, we're not moving ever. we're just staying right here. And chances are those people aren't calling us. We're gonna get a phone call from their children who want us to move everything that was in the house. So what people are really saying to us is they want to avoid going to a nursing home. Period. That's it. When they say I'm not moving out of this house, that's what they're trying to avoid most of the time. Or they may be saying, I'm going to remain independent at all costs and try and work on that. And that's what we're going to talk about today, is help folks remain independent.
So we're thinking whether you intend to stay put in your current residence or make a change, what we want to do is have you think of a new kind of a mantra or saying, and it's, I'm going to live the best life possible, and I'm going to surround myself with people who can help me do that. So that's part of what our panel is for today, is folks that can help you live your best life possible with the support systems you need to stay in your environment where you would like to be. So that's what today's topic is all about. And we're happy to have these ladies join us.
So today we have representatives from Grace Aging Service, Visiting Nursing, and Compassionate Crossing Community Care. And I'll let Kelly run with the introductions.
Sure. Okay. So
in no particular order.
Yes. But first up, we have Joelle Johns from Compassionate Crossing Community Care. So have a seat up here, Joelle. No, you can pick whichever one you want. You get the choice. Okay. Next, we have Denise Tufts, who is a licensed social worker from Grace Aging Services. And last but not least, we have Hannah Gonsalves from Northwest Clinical Liaison, Visiting Nurses and Rehab Services. And Hannah is a PT assistant, and we're going to learn more about what these ladies specifically do as we go through some of the questions.
So just some housekeeping as well before we really get started. So a microphone, when you're speaking, when it's your turn to speak, just grab the mic. It's not projecting into the audience because we don't need it, but it is helping to pick up the audio for the recordings. Okay. The restrooms, as you came down the elevator, are over to your right. You don't need a fob to get back upstairs if you need to leave early. We're planning on having time for questions and answers, so we'll try and have some time for that and get you out of here before noontime. So we can all go to Kimball's and have ice cream.
Super. All right.
Okay, take it away.
Okay, super. All right, get up on my chair. First of all, we're just going to do a little bit of introductions, just so the audience can learn a little bit about you. So, Hannah, why don't I start with you since you have the mic, and share a little bit about yourself, including your role with your company and how long you've been in this profession.
So I've been with VRNS for about a year and a half as a clinician. I was a PTA. So I was the first PTA actually in the Western Mass area. So we built up that region, and I just recently took on the role of the Northwest Clinical Liaison. So I'm covering all of Worcester County and then all of Western Massachusetts, working to help individuals get physical, occupational, speech, and nursing services in their own home.
Wonderful. Okay.
So I am Denise Tufts, and I own Grace Aging Services, which is an agency that provides in-home counseling for older adults as well as telehealth. And I've been in the field of human services about 30 years, but doing more older adult care for about the last 15 years. So I got into this profession because I really enjoy working with older adults and just see that they have different challenges as they get older and need specific services that are tailored to older adults between loss of function, loss of independence, grief, caregiver support. So, I do counseling to help with all those areas.
Great. Joelle?
Good morning. My name is Joelle Johns, and I am a board-certified clinical chaplain. I'm also a death doula, and I'm I'm an integrative thanatologist. It's all right if you don't know what that is. A lot of people don't. And I also do grief counseling. And I work for myself, which is the Compassionate Crossing Community Care. I'm also a hospice chaplain, and I am the outreach pastor for First Congregational in Princeton. I have been in human services since the day I walked out of college in '93, but really focused on seniors after moving to Florida in 2002, and have kind of been in that space since then.
Great. Excellent. All right, so many people want to age in place, as we're seeing in most of these seminars. That's kind of been the common thread, and we're always trying to help people do that. So can you briefly explain a little bit about which you kind of just did with your introductions, but what exactly home health care would involve in terms of PT, OT, and speech services? If someone were to need those services, is it only after an injury or an illness, or if someone's looking to get stronger, maybe do some exercises or come up with a plan so they can stay in their home? Can you talk a little bit about that?
Yep. So with PT, OT, and speech, we can come in after an acute injury if you're being discharged from the hospital or anything, so that would be more of a specific plan. But what's great about VRNS is that we do a lot of maintenance work. So sure, we'll see you after an acute injury, but it also helps you to maintain that progress and continue to get stronger. And it's great because it is in your own home. So it's everything relevant to you. You know, if there's a plan of care that you get after the hospital, or using equipment in your own home, or the people who are around you to help you do those so you can actually do them. You know, if you're going to an outpatient clinic, it might not be super realistic to do all the things you're doing there at home. So you'll feel safe, you'll feel comfortable, you're in your own environment. So that's what's very good about the in-home therapies.
I agree with that, because I know there's times when we've had folks that have gone home working in OT years ago that would need to practice stairs or practicing in and out of the tub. And so you go down the hall to a bathroom in somewhere that's not their tub, or it's not the type of stairs they have, or they might have a kind of a tricky step or a railing that's not exactly the same. So that makes a lot of sense to do it in their own home, really master it. All right, so Denise, along the same lines, some of the differences on your, why your services would be at home versus going to, say, a counseling appointment at a clinic somewhere.
Sure. When I opened my practice, I wanted it to be all in-home because the barriers to get out for elders can be significant, between transportation, physical limitations, and sometimes just stigma of going to an outpatient clinic. So initially my service was all in-home, and then with COVID it became telehealth, and now it's kind of a hybrid. Okay. So, but it is, I think, nice to meet in a client's home. I can see their environment, they're more comfortable, and that's why telehealth is kind of the second best thing. So
great. That's excellent. So the minimum requirements they would have is a computer for at home, or you can do it.
We can do it over the phone, yes. Medicare does
too.
pay for the phone.
Okay,
yeah.
Wonderful.
Which is probably the majority are over the phone, because a lot of older adults don't like to use Zoom.
Sure.
So we can do it over the phone, and then we do some in person.
Yeah.
But we're so busy that it's hard to do them all in person.
And I imagine that must be nice, because it's kind of like having a conversation with a friend,
Yes.
being able to just talk on the phone and takes a lot of the anxiety away,
Yes.
like you're saying.
Yes.
Great. All right. And then Joelle, of course, hospice, you're going to enlighten us a lot about that, but I know that from experience, most people's hospice is in their own home, but there's also hospice centers. But do you primarily see people in their own homes, or are you, other than doing your chaplain work when you're doing hospice? Tell a little bit about your in-home services.
I would love to say that people die in their own home, which is where I personally would want to die. Mm-hmm. I see a lot of people in skilled nursing who, this is sort of a layered discussion, and I'll try to parse it as small as I can. A lot of people wait to get on hospice, and just as a jumping off point, hospice is not a place per se. Hospice comes to you wherever you are. It's more of a philosophy of care. It's for comfort care when aggressive curative treatments are no longer considered helpful. A lot of people, including doctors, are not great at having that conversation and telling you when you're getting to the point where the curative stuff is doing more harm than good. So a lot of people will go into the hospital for an acute crisis of an illness that has been marching, unfortunately, along, and they will go to skill thinking that they're going to regain function back to where they were before. And unfortunately, that often does not happen. And again, I'm not talking if there's a knee replacement or a hip replacement, so let's make sure we keep that separate. But I'm talking with a chronic illness, and a lot of times folks end up on hospice in a skilled nursing facility. I get out to try and do education so that people plan ahead and do not have that be their outcome.
Okay, excellent. One question on that. Is there a true guideline in terms of if a doctor or physician were to give you a general idea of time left to live? I know I believe there used to be, if you have 12 months or less to live, you qualified for hospice. Is that still a thing, or was that ever accurate? Is there a time frame?
There is a time frame by Medicare guidelines, and it is a paid Medicare benefit. I know we'll get to that.
Yep.
It's 6 months or less.
6 months,
Now,
okay.
we're not great prognosticators. Nobody really is. Some people will then die within 2 weeks, and some people will be recertifying for years. That does happen, and we actually discharge people. But it's a conversation that if you think you're ready to have, you can also start the process. It doesn't have to be your doctor saying it. You can go to your doctor and say, hey, I know I'm pretty sick. Let's have that conversation.
Okay. I'm going to have you keep the mic, Joelle, because the next question is about cost. And so you just talked a little bit about Medicare qualifying for that. If in the event, like you just said, someone decided they wanted to call you on their own and feel like they're ready to get onto hospice, is hospice a free service? Is it a paid service? Is there a sliding scale? Is there anything you can share cost-wise that might be good information for folks?
It's a Medicare covered benefit.
Okay.
The only thing that I hasten to add, and is I cannot state this strongly enough, hospice doesn't move into your home. So if somebody needs things like incontinence care around the clock, that would be an additional out-of-pocket. That is not covered in a hospice benefit. So that is something to keep in mind. And some people can function just well having different family members go in and out, and some people will hire private duty.
Okay, great. All right, Denise, maybe you could talk a little bit about cost for your services in terms of if it's a telehealth or if you go to their home or things like that.
Sure. All the services are covered by Medicare or any insurance. They have all benefits for behavioral health. So typically, if someone has a copay, they would have a copay the same with me. But
Okay.
I'm able to bill, I'm contracted with all insurances, so I can bill all insurances.
Wonderful.
Yeah.
Okay.
So there's no
Excellent.
cost or copay.
Okay. And Hannah, how about you?
Yeah, similar to that. We do take all Mass Health and Medicare Part A and B. We do take some specialty plans as well, but we offer the private pay option
Okay.
as well.
Super. All right. And then for any of you ladies, maybe we could start with Hannah since you have the mic. Is there any financial assistance other than that if someone maybe didn't qualify for Medicare, maybe on some of the maintenance programs you talked about, and they may not have, or they may have private funds, but is there any other resources to qualify for
Right.
care?
Typically, we'll work with the individual social worker if they have one, and they can kind of help out with that. We do a lot of work with DDS and MRC. We work with the ABI waiver program. So that's more of like a maintenance program specific to Massachusetts.
Okay. And how would someone get into one of these programs? Is that something that a social worker would help them with?
Right, yeah, and
Okay.
that's under more Mass Health guidelines.
Okay.
And then they would have to have an acquired brain injury with that requirement.
For that group. Okay.
Right.
All right. I want to switch gears a little bit and talk a little bit more about the benefits. We did talk about how being at home and using your own environment, less anxiety and stress, being around family members, and of course, if the ideal situation for somebody, if they were to be able to pass at home in environment that's comfortable for them. Are there any other benefits that you can think of? We didn't talk about how the family or the client benefit from having these services in the home versus in a clinic or in a long-term care passing setting or, at a rehab center. Is there any other things that we didn't specifically bring up that are true benefits that you see or examples of something you've seen?
On top of environment and just comfort, being at home, I think it's great as a clinician. Like I've seen this firsthand, getting the whole team involved. So whether it's family members or other caregivers, everybody's kind of on the same page and can help the individual with whatever it is that they need.
Okay.
Yeah, and being in their own home, I think when it comes to counseling, they feel more comfortable. They're more open, maybe to talk about things. Plus, I could see what's kind of going around in their environment.
Yeah.
So I get a better feel for the whole situation. And although telehealth doesn't give us that, it's still easier for them because if they don't have transportation, some elders don't drive. So just giving them the opportunity to have a service still in their home is much more helpful.
Okay, that's great.
With hospice, the biggest benefit, of course, is it's no matter where you are, it's a very patient-centered, and the patient really drives the bus in terms of how much treatment, how little treatment, who they want there, if they want to volunteer. We also have a very egalitarian team, whereas the doctor, the chaplain, the nurse, the nursing aide, the social worker, all of our input is equally important because we're looking at the whole person. I will say that one of the things that I do, wearing my other hat about sort of end-of-life education and awareness, is I try to get people ahead of to be talking and having hard conversations before they need our services, so that if there are things that are unresolved, people maybe that you haven't spoken to in years, and it's really something that's kind of stuck with you, and family strife and things like that, talk about it. Use a counselor to help you work through that, because it's hard to see when those things come up and people haven't addressed them, and time is short.
Maybe before you pass the mic, if you could talk a little bit, Joelle, about being a doula. You mentioned that, and that's something different that I haven't really had much experience with. So if you could share a little bit about what makes you unique to be able to, with your certifications for that, and how you use that service, or folks use that service.
Oh, okay. Well, as a doula, I'm able to spend more time. In the chaplain space, it's a very highly regulated. It's Medicare. I have X amount of time, I have X amount of patients, and I have to sort of just keep moving through my day. As a doula, I can spend more time with the family, and I can do a lot of that unpacking and help to plan sort of the vigils. I can help get food to the house if the person's entering into sort of their final phase of end of life. And there's a lot more, that's more of a partnership. And it's a non-medical. I don't give medications in either job, but it's much more holistic, and that I can help the family have resources, and I can help them connect to resources and things that I cannot do as a chaplain. And I can also be there to provide the family respite if they want to get out for a few hours. I can stay with the person who's dying. I can't do that as a chaplain. So things like that.
Okay, that's great. All right, Denise. Oh,
No, ma'am. It is. Yeah.
okay. Denise, maybe a little bit about what also makes you different than other folks, or how a family might seek you out, given that there may be other counselors out there. What is some of the benefits why someone should choose working with you, or some of the special things that you can offer that others don't?
Sure. Well, I'm specifically trained in geriatrics. I went for grad school to be trained to work with older adults and their needs, which are quite different than younger people. So I think that makes a big difference, working with somebody that understands the aging process. And I mean, the biggest change is just the losses that older people have. So I have a lot of training in grief. So yeah, I think that's the biggest thing, is that I'm trained. And I have a few people that work with me part-time that are also geriatric clinicians.
Wonderful. That's That's good. Yeah, that's really important to have, to really know the population you're working with versus you've got a 16-year-old at 2 o'clock and then you've got a 40-year-old
Right.
and now you've got an 82-year-old. It's hard to kind of be all over the place and know all those sets of needs that people are going through.
Yes, I only see people over 60.
Okay,
Yes.
wonderful.
Yep.
All right. And now, Hannah, I know there's lots of home care companies around. Maybe you can share a little bit about your company and what makes it unique or different.
So similarly, we see a lot of similar populations, so our clinicians are very well versed when it comes to that, and we're very flexible in regards to the times, working with if you have other appointments, if you're having other caregivers come in, if we want to be there at a certain time, like a family member's there, so we can be all on the same page. So it's very good to working all together and kind of really being individualized for each person.
Okay, great. I'll let you hang on to that. We're going to talk next about referrals and the intake process. So how do you typically get referrals for new clients? And can someone contact your agency directly, or do you get from the doctor or the healthcare professional? We kind of talked a little bit about that already, but if someone were to come, a new intake would come into your
Right.
office, how does that typically look?
Yeah, so we get a lot of different referrals just because we are through the whole state. So we do work with some hospitals. We work directly with some MD offices. So we can get them right from there, especially if it's an acute injury or a discharge. But you can submit a referral right online too. So the only thing we would need would just be your relevant insurance information, your primary care providers, referral, and then you would talk to me for this if you're in this area, and then we have other regional liaisons too. So it would just be you're contacting us, we contact you, make sure we have all of our basic information, and then from there we kind of contact who we need to in order to get the rest of our information and begin to start a care.
Okay, great. And now how long, if you get that intake, until you would actually make the call the client to make an appointment is your what's your turnaround time?
Yeah, it would be, I would say, about a week or so, especially if you're coming to us with all of your information already, and we're not waiting for a discharge or anything. We just try to get it done as fast as possible.
Okay. So you're not going to call at 10 o'clock and you're going to show up at 2:30 like Amazon sometimes can.
Unfortunately, no.
Okay. But a week's reasonable. So to plan ahead and kind of be ready. Okay.
So I can receive referrals from doctor's offices, from the client themselves. They can just call me if they have my information. I get referrals from family members, neighbors, insurance companies that know of me will have case management that will refer them, senior centers, so whoever. They can do it over the phone. They can do it online through my website.
Okay.
But yeah.
And how is your schedule looking in terms of if a new client comes in? Do you have a couple week backup or?
Yes, unfortunately we do. We're very busy because we're one of the only people that do geriatric counseling.
Okay.
So right now we have a wait list about 6 to 8 weeks roughly.
Okay. All right.
So, yeah.
And do you have a typical, I guess it would depend on the client and their circumstances, but do you have a typical amount of visits you would see a person? Is it once a month, once a week, more than that?
It does depend. Typically, the first visit we do try to do in-home if possible to put a name to the face. And then typically it's every 2 weeks. If they're sort of in crisis, it can be every week for a little bit. And then it could be every 2 weeks. And then if they're stable, we could try to go to monthly.
Okay.
And then eventually, hopefully they're feeling better and we can transition. And then I've had people that have left and then 6 months later a crisis happens or the death and we can resume again.
Okay, great. All right. Joelle, anything you can add to that?
Yeah. First, to address her question back there, I do everything on a sliding scale that I do that for myself. That's private pay. Referrals for hospice usually come through doctor's offices, skilled nursing facilities. A lot of people don't know that they can self-refer, but you can. And I also encourage people to interview your hospice. You don't have to pick the one that necessarily shows up. You can ask what makes them different, what makes them unique, what do they bring to the table? Do they have pet therapy? Do they have music therapy? Do they ask all kinds of questions? You are not locked in. Actually, even if you do sign up, you can always say, no, I don't want to do this anymore. So I just want you to keep that in mind. But referrals for that side come in through the typical Medicare and private insurance and also Mass Health channels. But I do want people to know that you're empowered to start that conversation yourself.
That's good point. Now, do you have folks that will come on and off hospice sometimes? Like they'll be on it and then they start to perk up and they back off a little and then they'll call you back?
Absolutely. We just
Okay.
had a little lady that we discharged her at the end of last year, and she's back on now. She had
Okay.
a nice little bump for a while, and sometimes people really respond to the extra care. But she's back on now.
Okay.
And we'll take good care of her.
Yep, great. Okay, so I like that you're not locked into a contract. If you find someone that you're not clicking with for whatever reason, it's your life, your end of life, you want to make it the way that you want it. So that's a good point. Okay, let's see. So we talked a little bit about screening or your caregivers. You're just saying, meet the people, see if you like them, if you have a good rapport with them. In terms of importance of being licensed and being kind of vetted or being professionals, I know there's a lot of companies out there, kind of like we find when we're doing referrals for handyman services. There's Joe down the street that says, "Oh yeah, I can fix your roof," or I can do this, but Joe's not licensed or insured or hasn't been vetted. Then there's somebody else who's got all the qualifications, but they may not be the greatest fit for another reason. So how do you, I know you're all regulated and licensed in all your areas, but do you have any insight you can share with the audience in terms of some things they should look out for if they were to come in contact with someone they're not quite sure about that is certified or licensed? I mean, that's kind of a vague question, but any kind of tips that you could share, things to look out for if they're looking to hire someone? And then it's not one of you folks because you're out of their area or they need someone quicker or their family member lives somewhere else.
For me, and it depends on which lane I'm in terms of, there are minimum standards, of course, for Medicare to be a hospice that Medicare will reimburse. So there's sort of a boilerplate that they all have. It's the ancillary services that kind of get me excited, like if there's music therapy, pet therapy, what their volunteer structure is, those kinds of things. And for myself personally, for my counseling, I am insured, and I went through 1,600 hours of clinical training to become board certified, and I also went through 2 different trainings for the end-of-life doula. So people often have a digital footprint. Don't be afraid to look at it on like LinkedIn, those kinds of things, and you can sort of see what people what some of their credentials are and some of their former history, where they've worked, what their background is. So everyone has a trail.
Yes, good point. That's a good point.
I mean, in regards to therapy, I mean, anybody that's advertising as a therapist should have a license. So, I mean, you can check that online also. Yep. I think I do specific certifications and like dementia, and I take CEUs that are regarding older adults. So I have that training. I have professional liability insurance, as does everybody I work with. Yep. And I have to be credentialed with each insurance agency. So that makes, me able to take other insurances. So some people don't. So that's something you want to check, that they take your insurance. Else you'll have to pay private pay.
Yeah.
Yeah.
Okay. All right, super. Anything you want to add, Hannah?
I would just say, regardless of the services that you're looking for, just making sure that you're comfortable with your therapist or your caregiver. I think everybody has the right to say that for themselves.
Yeah, okay, excellent. Yeah, I know over the years, I'd have different patients who would have home health aides say, and some of them loved their home health aides, and other ones would say, oh, this one's on her phone all the time, or this one only shows up once every 5 visits because her car is always broken down, or her son's always sick, and you start to realize, is this person really helping me, or are they hurting me? So I think these are all good points, that if you feel in your gut that something's not quite right, or it's not the right fit, there's always another plan. There's always another alternative. So sometimes I think some seniors are afraid to speak up, and some people, not even seniors, are afraid to speak up. But it is always good to know that it is your life and your care. And if you're not driving the bus, as Joelle said, you need to be in charge of as much of it as you can to have the best outcome that you personally can. The last topic we're going to talk about is a little bit about care plans and communication. And we could start with you, Hannah, how you develop a care plan that's truly client-centered, and how you can address individuals' needs or preferences different than anyone else. We've talked a little bit about some of this stuff
Yeah.
already, but just to reiterate.
Right. So it kind of goes hand in hand with just being at home and being able to communicate with the family and the caregivers. Obviously, the individual comes first, and their needs and their goals are what we're going to focus on. But then being able to have everybody on board too kind of helps us to develop that plan and see what everybody is willing to do in order to give the best quality of care. Of course, that's our number one job, is to give quality care and the best kind of care. But if the individual's goal is to do the laundry on their own, like that's what we're going to be
That's what
doing
you're
every
gonna
week.
work on. Yeah. Okay.
And then obviously supplementing it with other things too, but definitely like individualizing each plan and getting the whole team on board.
Great. Okay.
Kind of along the same lines, we meet, the first initial session is to get some background history, and then for the client to really identify what they want to work on, whether it's their stress, their caregiver burden, their depression, but it's person-centered, so we meet and talk about what they want to talk about. Sometimes I have families that will call me and, can you meet with my mother and fix my mother, or make her stop doing this, or make my dad do this. So I'm like, I don't have a magic wand. I can't fix anybody, but it's very person-centered. It's very much what they want to work on. And it might be different in 2 weeks. Their friend may have passed away. And so now we're going to talk about their friend and more grief or loss, or a grandchild was born. So they're going to talk about that. And so every week or every meeting it is different, but we have goals, which is pretty generally to help their overall health get better, their quality of life, learn some coping skills, healthy coping skills. But I meet them where they're at and what they want to talk about.
Okay, wonderful.
Probably unique to the hospice lane is that sometimes the person coming on hospice has had, say, dementia for a long time. So we have to listen to what the family input is. And that is always when we hope somebody has done a living will, and if you haven't, please do so. When you put it on paper, it doesn't mean anything's going to happen. It just means that you're putting your wishes on paper. I promise, because I've been talking about death for a long time. I'm still here. So in that case, sometimes we have to defer. We want to advocate for the patient, but sometimes we have to defer to what the family is telling us, which is why I encourage that. In my chaplaincy, and when I do counseling, when I do outreach and counseling for Compassionate Crossing, I like to know, in terms of when I'm making a plan, I want to know I start with life review, because I want to know what has meaning, and I'm listening to hear, and I'm also listening to what you're not telling me, and what things seem to be purposefully avoided, or what, because the point for me is to sort of clear your table as you're facing this phase of your life. So it's a little bit different of a process, because because time is short, there's a little more urgency to kind of unpack some of those things. So, but we make a care plan. The hospice care plan is completely patient-centered around pain management, symptom management such as agitation, anxiety, all of those things. And hospice does that really, really well.
Great. Okay. So we've gone through most of the general topics that we were going to talk about, but I didn't know if you had some specific stories or anything that you might want to share, or something that we didn't talk about, either an experience you had with a patient, or some other advice to give to these folks in terms of, we're talking about doing things early, having your will done, reaching out for help if you need it, trying to live your best life. And is there anything that you would like to share that would help some of these folks maybe think of a client that they may know, a friend or family member that could use one of your services, or even for themselves, that to know when it's time to start thinking about, exploring some of these resources that are out there?
I can think of a client I've had. I think she's my longest client. And with counseling, it can be short-term, it can be long-term, as long as it's needed. So I started working with her because I think it was her family that might have referred her. They were concerned she was caring for her husband who had dementia at home. He was declining, so she was getting more stress, more burnout. So they really wanted her to just have somebody to talk to. So I would go to her home, and her husband was still there, and we met and we talked about ways to self-care for herself, which was really hard for her to learn how to take care of herself so she can be a better caregiver. So we kind of went through that process, and then he declined, and then he went on hospice at home. And so then he passed away. So then we kind of, our next working together was around grief and the loss of her husband and just the loss of being a wife and the role and not having her husband there. And then it's been a few years since he passed, but we still meet just to kind of check in with her overall mental health, how is she coping? She's having some health issues. So it can be kind of an up and down. I don't see her all the time. It's like monthly, so it can vary. But she's somebody that was open to counseling. I think a lot of older adults feel like a stigma still. Back in that generation, crazy people went, and I'm not crazy, and nobody, needs to have that thought process, but it is there still. So I think just trying to educate people that getting help for our mental health is very helpful for anybody, any age, but especially in aging, because there's so much loss, so much change, so much grief. So hopefully people are getting more accepting to that.
Yeah, that's great. It sounds like you were her person that she could count on, keep circling back as things changed in her life. She always had someone to go back to, and you knew her history. It's not like when sometimes you go to your physical and now you've got a new nurse practitioner and you start all over again, or you're on hold with Verizon and then they put you on the next person, you tell the whole story again, and it gets frustrating. You never feel like you move forward. But it sounds like you're really able to provide some really great support to people. So that's wonderful. Do people kind of try you out sometimes? Like, do you think I'm good for counseling? Do they want a session or two to see if it's helpful?
Yes, and sometimes I'll say, I'll kind of preface it like I'm a social worker. I'm not necessarily a therapist, because some people have a stigma with a therapist, or
Yep.
they've had a bad experience in the past. So I'll say, if you want to talk, we can try it. We can talk, we can visit, we can see how I can help you. And then if you don't feel it's helpful, then we don't have to.
Okay.
So I try, especially with people that are a little resistant, where their family has called and said, my dad's really depressed, my mom died, he doesn't leave the house, he doesn't think he needs counseling, but could you talk to him?
Yeah.
So I'll kind of preface it that way, like, give it a try.
Okay.
And they're very comfortable once they realize I'm not, there to put them in a hospital or
Right.
give them medication that they don't want or something.
Sure.
Yeah.
Okay. And then do you ever refer out to maybe a support group or something
Yes.
after a certain period of time?
Yes, I think because my training was in case management and human services, I'm always trying to find resources for people. So yes, if they're having caregiver burnout, we talk about support groups, or I have a lot of resources from trainings I've been to. So
Great.
if whatever will help them feel better, I will try to help them get a resource.
Wonderful.
To you, to other people.
Yes. All right. Great. Joelle, do you have anything you can think of, a story or something you want to share other that we didn't ask you about?
I can, and I will tell this nice woman back here that there are free grief groups at senior centers. I know because I run a bunch of them. There's grief and caregiver support from Holden and Sterling and Worcester, Gardner. So I'm all over the place doing those, and those are free. And if I do feel like somebody is struggling in particular in a way that group cannot, or they need like an added layer, I will send them to somebody else, and I'm happy to do that. I do have a story that I'd love to share.
Sure.
I did a talk at a senior center at Princeton, actually, on advanced directives, and we had a lovely time, and there was actually a very good turnout, and we had lots of laughs over kind of a dark topic, but it was great. And I met this lovely couple, and I chatted with them afterward, and then went about my business. And then a few months later, I had no idea that the gentleman was even ill. A few months later, the council president of my church called me on a Sunday night and said, "Hey, Dennis is dying." And I said, "Who are you talking about, Harry? I have no idea what you're talking about." And he said, "We just call them." So I did. and I will. He has passed, and I have full permission to share this story from his wife. Because it's so lovely, actually. So I called, and he wanted to meet with me the next day, so I put a call into my hospice and said, I think we're going to need to put somebody on service tomorrow, and I went to see him, and he told me he was ready. He had had cancer and had been in and out of the hospital, and he had been to the ER that day and said, I'm done. So we took him on service, and I got to be his chaplain. I was kind of a doula there too because of my relationship to the church, and this is all in the same town. And I got to spend a lot of time with them and unpack a lot of things and be there for the family. And then after he died, in his own bedroom in the house his parents had built, because good planning. It was peaceful, it was lovely, and then I eulogized him and presided over his celebration of life. So it was a very full circle experience, and I still keep in touch with the family. I still look after them, and I'm still involved in sort of the after effects of that and the grief journey. And so it's, to me, mental health is very, very important, and part of that, from my perspective, is to be comfortable with the fact that we are mortal beings and letting that inform how we live our lives. And so I think part of that is like the community care is having all of those components together.
Great story. It's true that the whole circle after someone dies, to be able to still connect with the family is really important, because after funeral services and the last thing of flowers arrives and the last couple notes, then there's a really quiet, long period of sometimes loneliness. And so to have someone to connect back with is really important, because oftentimes it seems like death is final and then the family's just kind of left to flounder. So that's great to hear you do that.
Kelly, I went hiking with her a couple of weeks ago and I couldn't keep up with her. She did it on stage.
That's great. That's wonderful. Really good. Great. Any story you'd like to share, Hannah, or think you'd think of?
Yeah, following that one.
I know, it's a tough one.
I just think it's important to, it's hard to ask for help, but I feel like there's plenty of people out here that want to give you help, whether it's for you or a family member or just a loved one. So just know that there's help, and advocate for yourself. If it's a company that you don't enjoy or you're not comfortable with your therapist or your caregiver, then you have lots of options.
Okay, great. Well, thank you, everybody. We do have, these ladies will be available for some questions. They have some information on the table if you want to take some of their brochures or things. We also do have an evaluation form at the back of our packet, which we always like your feedback. If there's anything that you'd like to see different, a topic maybe you'd like to see, or anything at all, we do read them, and we try to make these seminars better each month. So we would appreciate that if you could take a few minutes to fill it out. And there's also a form or a flyer for our next month's seminar, which is on, Jeff's going to talk about that.
So safeguarding senior homeowners, strategies to prevent scams and financial exploitation, either, did I misspell exploitation?
No, I think it's okay. Yeah.
Okay, it's good, yeah?
Yeah.
All right.
Yeah.
But we're gonna have Casey Freeman back to talk a little bit about what kind of internet scams are out there, and
Hopefully someone from the police department as well. There's lots of things going on for seniors and for everybody, for scams. But
in August, longevity unveiled, understanding the dynamics of stage versus age. And Joelle, I think you hit the nail on the head with trying to keep up with someone that's 86 while you're hiking.
yeah, right. We see very unhealthy.
So July 10th, it's always the second Wednesday of the month. July 10th and August 14th, same time, same place here. So what I'm hearing today, thank you very much, ladies, for being here today, and thank you, Kelly, for great work presiding over this wonderful panel.
Thank you.
You can do it every month now. What I'm hearing is, and we seem to kind of keep coming back with the same kind of theme, is prepare and try and get ahead of these things. Last month we talked about preparing wills and estate planning. making those plans, those kind of things, and not waiting for the event to unveil. But life goes on as well. But there's support there. And I'm glad to hear you talk about the support of the caregiver as well,
Yeah.
which is more and more the case. That someone in the home is needing the help, but the person that's giving the help always needs the help too. So, if anybody has any other questions? Okay, Michelle. I think you do. Come very well prepared.
Hi, Denise. I'm Michelle Morin. How are you? So we were at an event last night, and Peter McDonald had mentioned that there are only 311 geriatricians in the state of Massachusetts. Mm-hmm. My question to you is, what enticed you to be in this field?
I look back and I think it was my grandmother was a very important person in my life, and I felt comfortable and loved by her. And so as I went through my career, I worked with clients with mental health issues, and I always would gravitate towards the older ones. And so when I was going back for my master's, I just knew that I wanted to work with older people, and it just is like my passion. And I just find they have so much wisdom and experience that I enjoy spending time with them and learning from them. And so I was lucky enough to find school that I could get trained, specifically in geriatrics, in mental health. So it's kind of been my thing. Thank you.
Anyone else? All right. Well, thank you so much, and we'll see you next month, everyone.
Yeah, thank you.
Thank you.
Bring a friend or two. Excellent.
They were
Almost
comfortable. I
took
know.
myself over. Good job, ladies.
Snazzy too.
Thank you. Yeah, thanks for
Yeah, I want to get some of your.